Something known as a three-column construct that is oftentimes used by surgeons when performing preoperative planning. So this is a simple method for evaluating the gross stability of the spinal column. And so to do this, the surgeons will look at the spinal column in three separated columns with an anterior column, a middle column, and a posterior column. So the anterior column consists of the anterior longitudinal ligament as well as the anterior two-thirds of the vertebral body and the corresponding annulus fibrosus associated with it. And so the primary function of the anterior column is to primarily bear the majority of the axial load. So that's the load of the weight placed upon the spinal column. It also helps to resist extension, as you'd imagine, with the anterior longitudinal ligament forming a component of that anterior column. The middle column is comprised then of the posterior one-third of the vertebral body, as well as the corresponding annulus fibrosus, including the nucleus pulposus as well, and then also the posterior longitudinal ligament. And so, as you'd imagine, with the posterior longitudinal ligament being a component of the middle column, one of its primary functions is going to be to resist flexion, and it's also going to then bear some amount of the axial load, as you'd imagine, with one-third of it being the vertebral body, annulus fibrosus, and nucleus pulposus of the IV discs. Finally, then we have the posterior column, and the posterior column has multiple elements, as you'd imagine. It's going to consist of everything posterior to the vertebral body, so it's going to include the pedicles, facets, obviously the laminae, the ligamentum flavum, interspinous and supraspinous ligaments. And so that part of the posterior column is going to help resist flexion to some extent. Of course, the posterior longitudinal ligament is going to play that function as well. But then the posterior column is also going to play an important role in stability during rotational movements and lateral bending. So when you're moving your spine from left to right, so you're turning your body, that's going to be an important aspect of the posterior column. And then lateral bending, so bending from one side to the other. These components of the posterior column are going to be really, really important for resisting abnormal or too much movement. So too much rotation or too much lateral bending obviously is not a good thing. And so this posterior column is going to play a significant role in preventing over rotation or hyper flexion in a lateral direction. So looking at what these columns look like, you can see the red represents the anterior column, the middle represents the blue represents the middle column, and the green represents the posterior column. And then here we have a lateral view, so you can see this represented here. You can see the vertebral body, the sort of the anterior two-thirds of it. Here's the posterior one-third, and then posteriorly we have the pedicles on back all the way to the spinous processes. And so looking at a textbook view of what this looks like, we can see, again, the components of these columns. So you can see the anterior column here in red, the middle column here in blue, where, again, you can see the nucleus pulposus, annulus fibrosus, and the posterior one-third or so of the vertebral bodies. And then finally, the posterior column representing the pedicles all the way back through the ligamenta flava, the spinous process, and the interspinous and supraspinous ligaments. All right, so then this leads us into another important couple of relationships that you want to be aware of when evaluating the C-spine. So this is going to include the Bajan-Dens interval. So you can see that this arrow drawn right here represents that interval. And so the Bajan, remember, is going to be the anterior-most aspect of the skull base around the foramen magnum. And this is going to come into close proximity with the Dens. And so there's a typical again, this should be relatively closely approximated, and so if they are not, as is the case here, where you can see the Bajan located at this white dot, and then the Dens, you can see kind of all of it looping up right here, and so obviously that is a very far distance. They're not closely approximated to each other, and so this is indicative of an atlanto-occipital dislocation. However, this is not all that reliable in children under the age of 13, and so that leads us to another potential or another useful interval to pay attention to, and this is called the Bayesian axial line interval, or simply the Bayesian axial interval. And this is going to be performed or evaluated by drawing a line along the posterior aspect of the dens, and you just follow that line all the way up, and then that should be again in close proximity to the Bayesian. So this distance between this red line and the Bayesian should not exceed 12 millimeters, and that is reproducible and reliable and include in adults as well as children under the age of 13, which makes this a very useful landmark to pay attention to when evaluating the C-spine. So here we have an example of an atlanto-occipital dislocation in a 10-year-old girl. And so here we actually are able to appreciate where, if you draw a line along the posterior aspect of the dens, and then you measure that distance between the dens line, so posterior axial line, and the Bayesian, you'll notice that is a very far distance, much greater than about 12 millimeters. And so that is indicative of this of such a dislocation of the craniocervical junction. All right, another region to be sure to pay attention to is the pre-dens space. So again, this is going to be the small amount of space located in between the anterior arch of C1 and the dens of the axis. And so again, you can see this little space right here represents the pre-dens space. And so that's typically around 3 millimeters, give or take, but it should not be wider than 3 millimeters. And so that's what you'd be looking at there. Whereas the Bayesian dens interval that we talked about before, that should be less than 10 millimeters in distance, and then this Bayesian axial interval, as we discussed prior, that should be less than 12 millimeters. So just to review those again, so atlanto or pre-dens space, the atlantodental interval or pre-dens space should be less than 3 millimeters. Bayesian dens interval should be less than 10 millimeters. And then finally, the Bayesian axial interval should be less than 12 millimeters. All right, so I mentioned before that oftentimes it's difficult to appreciate the C1 and C2 vertebrae in many C-spine radiographs. And so this is a useful view called the odontoid view. So this is where you can appreciate the dens in C2 as well as C1 quite well by having the patient open their mouth when the x-ray is being shot. And so we can see how this frames C1 and C2 for us. So the dens should be upright and have sort of this trapezoidal or without any sort of transverse lines. C1 should have this sort of trapezoidal appearance to it. And then you should notice that the lateral margin of C1 should be aligned with the lateral margin of C2 within about 3 millimeters. So if you see a significant lateral deviation here of C1 relative to C2, that's usually indicative of a burst fracture or Jefferson fracture of C1. Another thing to note with any sort of unstable C-spine, so in the case of trauma, in many cases it's not safe to manipulate the patient's head and neck before you understand exactly what the fracture pattern is, or confirm whether or not there is a fracture. And so you'll notice that this is an approach that we can take, which is called a cross-table lateral view of the C-spine. And so you can see where the x-ray is shot across the patient's neck while they're laying on a table, and then there's the film on the other side. And so this allows us to maintain cervical immobilization while we're performing the scan. But you'll see how it does complicate. It's a limited exam. It doesn't give you the greatest view, but it does allow you to at least get a rough guesstimate of what might be going on with the patient's C-spine, if anything. You also notice in this patient you can see the ET tube or the endotracheal tube where they've been intubated. So something else that you want to make sure you assess on these C-spine scans are the soft tissues. You want to check the prevertebral soft tissue, so everything that's just anterior to the vertebral bodies. So this should be less than 10 millimeters at C1, less than 7 millimeters at C3 due to the oral pharynx and where we're transitioning into the trachea. You can see down here going through the larynx into the trachea, with the esophagus coming back here posteriorly. And so as a result of the esophagus located back here, or distal to this location, you can see at the C7 level, we should expect less than 21 millimeters of prevertebral soft tissue at that location. So here we have an example where we're looking at the prevertebral soft tissues and various spaces. So you want to make sure you also pay attention to these spaces. So you can see space 1 right here represents the nasopharynx. Space 2 represents the oropharynx. You can see number 3 here is the soft palate. Number 4 is going to be the base of the tongue. 5 is the epiglottis. You can see the hyoid bone should be at approximately the level of C3. So that's an important relationship to make sure that you know hyoid is approximately the C3 spinal level. So that gives you a landmark to help you identify the C3 vertebra. You can see 8 here represents the proximal trachea. So all of this here, or sorry, esophagus rather. So this is the proximal esophagus all through here, number 8. Number 6 here represents the larynx moving down into the trachea down here, number 7. So you'll notice that there's an abnormality in this scan, so I'll give you a second to look at it and see if you can identify what the abnormality is. And it's not necessarily an abnormality per se, it's actually more of a normal variant, but you should notice here on the patient's left, you can see that they have a cervical rib. So you can see coming off the T1 where the first rib is located, second rib, third rib, etc. But you'll see coming off C7, there's an additional cervical rib coming off right there. Okay, in some cases it can be difficult to see the upper half of T1. I mentioned before that you should be able to see the superior half of, or superior tip at least, superior border of the T1 vertebra on a typical neck radiograph, but in some cases it's not possible to see it, and so in that case a swimmer's view is usually taken in order to provide a good view of C7 and T1. So you can see here where the patient's arm is placed into a extended position, or flexed position rather, with the humerus, so you can see the arm pointed up, and then that usually allows you to be able to visualize C7 and the T1 vertebral bodies. Here we have another example of an abnormality in the cervical spine. So take a moment, just a moment here to take a look at that and see if you can identify where the deficit or the defect is located. So here you can notice in the vertebral body of C4, you'll notice that there's an evident fracture located right there. And so this is known as a teardrop fracture. So you can see where the anterior longitudinal ligament is also disrupted. So here you have a lateral view where you can see that teardrop fracture. And so this is a flexion teardrop fracture is the full name, and this oftentimes will result in spinal cord compression, and often is also oftentimes accompanied by a spinous process fracture as well as a result of that hyperflexion type injury. Here we have another abnormality on this scan, so take just a moment to look at it and see if you can identify the abnormality. And so there you can see that the pre-dens space is widened compared to what you'd normally expect, and so that is indicative of a fracture here around C1. And then also notice that the lordotic curvature has actually been reversed, so it's normally you'd expect it to be kind of producing this lordotic curve. Now you have more of a kyphotic curvature, and so that is also indicative of abnormality in the cervical spine. So looking at a zoomed in view here, you can see that widening of the pre-dens interval. And then a view of the both C1 and C2 here, you can see where C1 has the lateral masses of C1 have been pushed out laterally relative to the C2 lateral masses, and so this is another indication that there's likely been a burst fracture here. And so here you can see the fracture in C1 on two different locations in this person, one on the lateral aspect of the posterior arch, and then another one through the lateral aspect of the anterior arch up here. And so, again, lateral displacement of C1 indicates a burst fracture, which is also known as a Jefferson fracture. So, again, if you see this lateral displacement of the C1 lateral masses, that again will indicate that there's likely been a Jefferson fracture of C1 in that patient. This is just an example of a 4-part burst fracture where you have 4 distinct fracture locations, and so that's going to cause this very significant lateral movement of the C1 lateral masses.